You go back. This is the first time that we've done this as a live collaboration between Seattle and LA over to Bangkok, united by AO Spine around the world, and we thank Globus for their eminent support. We have a lot of people online, so thank you so much. And again, the format of this is very simple. There's a collaboration of our SSF TV group, and Alexis is live in Seattle, and our Global Spine Journal team. Next to me is my co-editor-in-chief. Do you mind just standing up for a second so the camera can see you and say hi?
Hi. Oh. Good morning. My name is Carsten Wiechert. I'm a spine surgeon from Hamburg in Germany, and yeah, very honored and happy to be part of this inaugural Global Spine Journal Club.
So I want to get out of your way in a second, but want to thank AO Spine for facilitating this. And this is a great atmosphere at the Global Spine Congress, the 15th anniversary. With us is our managing editor, Donnie Lieberman, and she'll have a microphone later also. As you know, we run a very tight ship with our productions at SSF TV. The format is as stated. We have 4 presentations and we use Global Spine Journal content only. We have over 8,000 articles that we've now accumulated with multiple collections. And our kind fellows from USC and from the Swedish Neuroscience Institute, who we'll introduce in a second, have selected 4 articles from that. We'll have 7 minutes presentation time, 8 minutes discussion time, and we'll move on. And your questions will be invited. And again, this is the time format. So with this, and without much further ado, I'll step out of the way for the leadoff batter, and that's Dr. Neil Patel.
All right, good morning, everyone. So my article is about Interobserver reliability of classification of TLIC scores. And we'll go through that. All right, so thoracolumbar spine fractures are common, pretty serious injuries, and accurate classification is important. So this article looked at A3 and A4 injuries without neurologic deficits. So to the left is your A3 and A4 injuries, incomplete and complete burst. And the way they are defined is you have 1 end plate involvement versus 2. And then there are people, discussing operative versus non-operative management for these injuries. And of course, if there's no neurologic involvement, then your TLIC score is pretty low. So you could think about maybe non-op management. So for operative, proponents of operative management would say that there's increase in degrees of anterior column comminution, increase in stability, and sagittal plane deformity progression. So, but non-operatively, you could say, hey, is there any clinical significance to this? Again, operative modern surgery is safe, effective, and non-operative wise, you could say, hey, there is possibility of risks, right? The risk not zero, so why should we operate? So it's clinical equipoise in A3-4 injuries, especially with no neurological involvement. So how do we go about discussing this? And the next step to this process would be stability, right? Think of, does the mechanism of injury that cause A3 or A4 burst fracture cause enough posterior ligamentous complex injury that this becomes unstable? And if it's unstable, then it's operative. So we have to think of that, and that's why M1 modifier becomes important, and that's why this paper is significant in terms of looking at that. So this paper looked at reliability. It's a reliability study that looked at 22 spine trauma experts' opinions on this, and they looked at 183 CT scans only, so no MRI. And the experts assessed radiographic features and classified these injuries and rendered their treatment recommendations. So again, this is kind of a survey that was presented to the experts, and you can see there's primary index, primary injury, which is A1, A2, A3, et cetera. There are modifiers, M1, M2, et cetera. And then they looked at other things like PLC, how much of PLC is involved, and they had to give a number between 0 to 100%. And again, same thing with vertebral body damage, 0 to 100%, et cetera. So table 1 kind of looked at inclusion criteria, and again, adults 18 to 65 years old were involved, A3 and A4 CT in fractures and CT scans, TLIC scores between 2 and 5. Again, that's TLIC score down there, and you can see that the other points that could have been accumulated on these helix scores were excluded, so only intact patients were involved in this study. And the fracture management was pretty acute, so within 10 days. This exclusion, again, just talks about different things, prisoners, pregnancy, etc. So reliability of AO Telix in differentiating A3 and A4. So they looked at 71 patients out of the scans that they had that had A3 and A4 injuries. And again, you can see that the kappa score, the higher the score, the better the correlation. And then and you can see that that score there was 0.46. It's about moderate. And again, with interclass correlations was also moderate for single measures, but when they averaged it out, it was excellent. And similarly with M1 modifier, it didn't make significant difference. A3 and A4 correlation was pretty fair in kappa, but there was good interclass correlation when they looked at A3-4 injuries when they averaged everything out. So it looked pretty good there. Again, when they grouped it, again, M1 modifier came out to be about 37.1% responders that utilized this M1 modifier when they were looking at PLC injuries. And again, so I think the conclusion from this table was there's overall agreement in fracture classification was substantial. The agreement between A3 and A4 injuries was excellent. M1 modifier was there's fair agreement between the raters, and there was significantly increased M1 modifier use when the higher injury grades were present. So A3 versus A4, there were higher use of M1 modifier and A4, which makes sense if some injury caused both end plate damage above and below, then there's higher chance of PLC injury. So that makes sense there. The limitations of this study were that they had to exclude one expert because there was considerable variation in his or her opinion, and there was only universal agreement in 71 out of 183 cases. So for me, the takeaway is that, again, this study only looked at CT scans to look at A3 versus A4 and PLC. I think we should look at MRI as well and correlate that better. And if there is posterior ligamentous complex injury, then it makes sense in this day and age to stabilize to reduce further complications in the future. So that's what I got out of it.
Great job. Great job. Thank you, Neil. So we've been joined by Dr. Jeff Wong, and again, congratulations on yet another successful 15th Global Spine Congress, over 2,000 people. Thank you. So this is a great deal, and again, I'm happy to tell you that the AO Spine classification posters and sheets have been all removed. People love them so much. I would love to ask one of our audience members, and maybe Dr. Ashraf Al-Nagi, to take my place here and just talk to us about AO classification. Has this become a clinical reality? Everybody talks about TLIX. I still hear 3 columns. So just come here and sit down, take the microphone, and then ask some questions maybe to Neil about his interpretation of the study. So this is Dr. Ashraf Al-Naga. He's assistant professor at UCSF.
Well, thank you so much. And this is such a wonderful program, and just being able to connect with everyone across the globe is incredible. Yeah, so the AO classification is a routine part of our assessment of these injuries. It's how we teach thoracolumbar injuries to our trainees. It does a great job of really simplifying the biomechanics involved in spine. So you either have failure of the anterior column, or you have failure of the posterior tension band, or failure of both. And that really guides not only whether or not we need to do something, which was the advantage of the prior TLIX classification, where the TLIX scoring system would tell you whether or not to do something. But having an understanding of the AO spine classification gives you a better idea of what to do in the setting of having to do something. So, yeah. So, so let's go back to your slides here.
Can't. Hold on.
I have one question to you. Was, in your perspective as a young trauma faculty at a major urban trauma center, the addition of A4 a helpful addition, or did it confuse matters more?
You know, I in my mind, the A3s and A4s are still burst fractures. And I think the thing that becomes most difficult is assessing stability, right? So we could always go back to, the White and Punjabi definition of stability, which is the ability to resist, which is the ability to withstand physiologic loads so that there's no additional displacement. And so I think when I actually wanted to ask you a question about what your thoughts were about utilize, like how you felt about utilizing CT alone to assess stability, because that becomes really the difficulty. The McCormick classification tried to address this in the mid-90s, but that was in a different setting. And so is there utility for other imaging modalities such as MRI or upright X-rays?
Dr. Mohammed Milibari from Saudi Arabia. I think the most important thing, the difference between dentistry column and the telex score is the involvement of the end plates. If it is one end plate, upper or lower, or two end plate, it is the main different. This is main a lot of complication and intervention.
Yeah.
Yeah,
I
so the
agree with
question in
you.
terms of imaging to assess stability on one static image, what are your thoughts?
I think we need more data, and now we have more data. We are generating so much data, as we talked about yesterday, more than any other industry in the whole world. And so MRI is important, and I think we need to move on to that. Look at not just the vertebral body end plate involvement, because end plate involvement on CT may be different than end plate involvement on MRI, where it could show T2 signal change and signal change within the vertebral body, and then also look at posterior ligamental complex better. And if we do that, then this equipoise goes away. This instability is answered, and we need to then operate.
And so the next question I would sort of pose to you with that answer is the authors of the TLX study group, they subsequently looked at the sensitivity and specificity of MRI in terms of determining or assessing a PLC injury, and showed that it didn't correlate to the intraoperative findings. So does MRI sometimes cloud the picture if you see a little bit of edema without a frank tear? Like, that's the situation where it's hard for me to make an assessment.
And I think that's where the third step comes in, right? Because we're talking about data. So what about flexion extension images, if you really think, or loading images upright to see if that really moves? So again, more information and more data points added to this.
It looks like there's another question from the audience here.
Yeah, please.
Hi, my name is David Gendelberg. I'm also an assistant professor at UCSF. Me and Dr. Alnaga love debating these topics with each other. And I just wanted to point out one thing, that based on the AO thoracolumbar classification, if the PLC is violated, it then becomes a B2, and it's not a burst fracture anymore. And so really, I think the utility of this study is more to assess whether it's actually a burst fracture versus a more unstable B1 or B2 fracture. And that's why I think the utility of this study is, because yes, you get the CT, you don't know yet if it's a flexion distraction injury. And that's where kind of, I think, the Interobserver reliability comes into play in this study.
That's a great point. Thank you so much.
I guess. Moving onwards, and I thank our faculty from UCSF to serve as guest discussers. Again, Global Spine Journal, over 8,000, actually that's corrected, 800 articles over time, and many of them in trauma. And I want to thank my co-editors, Karsten and Jeff, for being here, and our managing editor. And next, we're going to have one of our fellows, Dr. come up here, Cliff Pierre, and he has selected an article, and then we'll have two article presentations by our USC colleagues. So, Cliff.
Good morning, everyone, or Sawadee Ka in Thailand. So again, thanks for the kind introduction, Dr. Chapman. I'd like to discuss one of the focus articles from the special issue of Global Spine Journal titled Using Equipoise to Determine Radiographic Characteristics Leading to Agreement on Best Treatment for Thoracolumbar Burst Fractures Without Neurologic Deficits. This study was done by Dr. Dan Durand et al., who's out in Vancouver with the rest of the experts. And one thing, as discussed earlier in Dr. Patel's presentation, again, thoracolumbar burst fractures represent a majority of all thoracolumbar injuries. And despite this frequent pathology that many of you here in our community quite sees, there is still no consensus with respect to indications for surgical treatment for patients without neurologic deficits. And the current literature on this topic is mixed and inconclusive with respect to the results. and the various recommendations as well as treatment algorithms as shown in some of these previous articles. Again, there being no consensus on how to manage these patients without neurologic deficits. So this is where it brings into question this idea of clinical equipoise. And to address this clinical dilemma of how to manage these patients, this group sought out to evaluate specifically what equipoise was. And again, in medical context, clinical equipoise is studied in many clinical trials, and how it was applied here in this study was amongst an expert group that found, again, if medical trials showed that there was an agreement greater than 70 or 80% amongst the experts, many of the research medical ethics found that this was in fact unethical. And so the group sought to assess radiographic characteristics associated with the agreement or disagreement in how to manage these patients, whether with surgery or non-operative management, that specifically had these thoracolumbar fractures. As discussed before, this same expert group from the AO Spine Knowledge Forum had evaluated 183 cases with thoracolumbar fractures, specifically asked those 4 questions: classifying the fracture, whether they were confident or not the posterior ligament complex was disrupted, as well as in this study, the degree of vertebral body comminution that occurred, and in which treatment group that they would place it in, surgery or non-operative. Now, of this 22 expert group, the threshold number for equipoise is 77%, which is magical number of 18 surgeons. So if 18 surgeons or more agreed, then this was a consensus group of agreement. And if 17 or less agreed on one particular treatment, it would be equipoise. And so of the 183 cases, only 8 of those cases found full consensus related to management. 6 of those being all reviewers said this should be managed surgically, and 2 said non-operatively. And amongst the equipoise group, or the uncertain group, they found that many of these fractures were A3, A4, and most commonly fractures versus the agreement group. And as discussed earlier by Dr. Gendelberg when he came up, if there was concern for how much of the PLC might have been involved, this bumps it up to a B-type related fracture. And so here in this table, it discusses the degree of how certain were these surgeons were that there was a posterior ligament complex injury. And again, in the agreement group, they found that it was a little higher than the uncertain group. Now, again, in this study versus other studies that were answering this question from a binary perspective, this one asked it in a continuous variable perspective, 0% being no injury at all to 100% being absolutely confident that the PLC was disrupted. Brings me to the next question, the modifiers. Now, if there was any concern of the injury to the posterior tension band, you can use this M1 modifier. And so again, studying the equipoise thresholds, they found that there was overall slight reliability in the equipoise group, the uncertain group, of whether there was any N1 modifier that could be applied, and it was fair in the agreement group of those who totally agreed. Now, one thing that Dr. Chapman always asks us to do is look at the numbers specifically. So in 100% agreement, the number is 49.7, whereas the total disagreement is 48.5. So this slight variation shows that, you know, particularly at least when it's respect to the degree of comminution, this example of how bad the vertebral body was is probably not well studied, which will just be discussed later on by one of our other colleagues in terms of the treatment algorithm for fractures. And so again, recap, assessing radiographic factors, these questions, fracture classification, PLC injury or M1 modifier, or vertebral body comminution to study A3 or A4 fractures. And again, the group, despite the 8 cases that they fully agreed on, there was high equipoise among the group, or uncertainty with related to treatment. And so again, fully analyzing these cases, there was poor agreement with respect to classification, degree of comminution, or PLC injury. And so some of the limitations. Now, while this was a prospective multi-center cohort, many of the surgeons might not represent all clinical environments around the world. And this is a global spine congress. So in certain countries or certain healthcare systems, your treatment recommendations may differ based on some of the limited resources. So if you are not able to obtain an MRI to evaluate, you know, further characteristics related to the posterior tension band or edema or other factors, this might play into your treatment recommendations. The equipoise threshold was based on limited literature. So this threshold could be set differently if it was managing different treatments or different pathologies, as well as other radiographic reliability studies have inherent limitations because of this spectrum of interpretation from morphology all the way to management. So in conclusion, again, more discussion related to this optimal treatment for thoracolumbar burst fractures remains controversial. The equipoise group found that many of their classifications were A3, A4 fractures. The agreement group had high degree of certainty that the PLC was injured, and more of those fractures were bumped up to related type B fractures. And then future studies need to continue to evaluate the role of the vertebral body with respect to the degree of comminution, as well as management.
Great job, Cliff. Thank you. Cliff Pierre is one of our fellows, and that's a really nice slide. I love that Thai flag in there. So we have a couple of questions from around the world, but I'm going to ask our colleague, Dr. Bartolome Mare from Santiago, to come here to my seat. Okay, he's one of our senior faculty members in AO Spine from the first hours. Bartolome, so we don't have a good conclusion on MRIs. How actionable is it? Tell us your perspective as a longtime AO member. How do we get to a better treatment consensus using MRI or using diagnostic tools?
Well, I think MRI has the value to determine about the posterior complex compromise.
Yes.
But I have heard here that you are talking about that in terms of type A fracture, type A3 or A4, which confuse a little bit the whole thing. But when you are talking, when we are talking about the posterior complex compromise, then it's not anymore a type A fracture, it's type B.
Mm-hmm.
And type B fracture is much more unstable, unless it is through the bones, like a chance fracture. Yeah. So in this term, I think it's a very useful tool in determining the instability, I mean, of when it's compromised, the posterior ligament. And also the MRI it's a helpful tool for determining the compromise of other levels. I mean, that you are not able to see in the CT scan because you have some edema, and then you will decide which levels you're gonna fix, trying always to be as short as you can to preserve the motion segments.
So in our country, MRI has become a reality. We always said if you're neurologically intact, you don't need to get an MRI, but our younger generation now, they order an MRI. It's not even them anymore. It's our ERs. They get MRIs routinely, and they're too sensitive. What do you think about them being just too sensitive? I mean, sometimes it's very clear that there's a disruption, but frequently it's just too sensitive. There's a little high signal. So how do we kind of, and this is, I think, what's at the bottom of this equipoise, this diagnostic equipoise. How do we make better sense of the MRI? Do we streamline our diagnostic criteria? Do we look for another signal, or do we actually rely on a physical exam of, does this hurt?
In terms of the compromise of the posterior complex ligament, what is for me a pathognomonical sign is when you see the disruption of the yellow ligament. And you can see this from time to time, but this is in type B fractures. This is not anymore a type A fracture. I don't have it.
So I still think personally, the simplest thing is to examine the patients. And this is something that I don't
Perfect.
like.
You have to put your finger in between the spinal process, and then it's very cheap, and it costs you nothing. But it's very often, at least in the emergency room in my country, with not spinal specialists, that they never examine the back of the patient.
Yeah.
They ask an MRI. Even though in my country, in my practice, I always have a CT scan, an MRI, and X-ray to take my decision in terms of the treatment of these kind of fractures.
Well, thank you for coming up to the
Well,
stage.
thank you for inviting me.
But this discussion also shows the limits you might find in especially automatic classification, deep learning algorithms, things like that. I mean, there's a lot of discussion, and there's still some some level of disagreement as we have just seen. So that does show the limits you would find maybe on a machine learning or artificial intelligence classification algorithm that's out there.
Great point. Let's move on, and maybe Dr. Jeff Wong, our chairman and the founder of the Global Spine Congress, can take the stage and introduce the next two speakers.
Great. So I want to thank everyone for coming, but I also want to thank the Seattle Science Foundation, and I want to give a personal thanks to Jens Chapman for creating this journal club and really pushing the collaboration between the Global Spine Journal and the Seattle Science Foundation. So I want to say a big round of applause for Jens Chap. So now I'm about to introduce two of the best fellows you guys are ever going to hear from. They're so excited to talk to you guys. They're competing to see who could go first. Which is the article that's going next? I want to make sure I get the right one. Oh, it's Michael. So this is one of our spine fellows, Michael Ang, who's going to talk about the next article. What you'll notice is that we took him because he lifts a lot of weights. He's very large and hopefully injected his steroids before he came up here. So with that, Michael, I invite you up here to present the next article.
All right, I'll be presenting the next article titled Rate and Predictors of Failure in Conservative Management of Stable Thoracolumbar Burst Fractures, a Systematic Review and Meta-Analysis. No disclosures. So introduction, obviously this is a very controversial topic, management of stable thoracolumbar burst fractures without neurologic deficit. Multiple studies have shown that non-operative and operative management are utilized for similar fracture patterns, and prior studies have demonstrated equivalence in treatment outcomes. There's also been studies that have shown orthosis versus no orthosis shows no significant difference in outcomes. And a subset of these patients that are non-operatively managed do fail conservative treatment and require surgical intervention. So the study of this, or the goals of this study were, one, to determine the rate of failure of non-operative treatment, and two, to analyze the prognostic factors at the time of admission influencing failure of non-operative management in neurologically intact patients with traumatic thoracolumbar burst fracture without posterior osteoligamentous injury. Some quick definitions for the study. They defined failure of conservative management as the need for surgical management within 6 months of injury after initial conservative management, and conservative management was defined as all non-operative interventions, including mandatory bed rest, early ambulation, physical therapy, body casting, orthotic devices, and closed reductions. Inclusion criteria included adult patients 18 or older. They had to be neurologically intact and have a traumatic burst fracture. The studies included were retrospective and prospective studies with at least 10 consecutive patients. And they must report rates of conservative management failure and or statistically significant predictors of conservative management failures. They had a minimum duration of 6 months of mean follow-up. And then they included the T10 to L3 levels for determining rate of failure of conservative management, and T10 to L5 levels for determining predictors of conservative management failure. Exclusion criteria included osteoporotic fractures or pathologic fractures, and patients with ankylosing spondylitis or DISH, and any patients with multiple fracture types if there was no subgroup analysis of burst fractures included. Study selection ran from January 1st for 1995 to May 29th, 2021. Keywords for their searches are listed there, and ultimately boiled down to 11 studies on conservative management failure rate and 5 studies on predictive factors of conservative management failure. Looking at the rate of conservative management failure, this is a somewhat busy slide, so I'll try to sort of filter it down a little bit. Looking at there were 11 studies included, 3 of which were randomized controlled trials, 8 cohort studies, 2 of which were prospective studies totaling 601 patients. Looking a little closer at the randomized controlled trials, Bailey et al. Had 6 patients that failed conservative management and required surgery for various reasons. Stadthalter et al. Did have 1 patient in the orthotic brace group that required surgery for progressive deformity with pain, and then a study by Wood et al. Showed no significant difference in functional outcomes between the treatment arms and no failure of conservative management on follow-up. A pooled analysis of the 601 patients included showed a rate of failure of conservative management of thoracolumbar burst fractures of 9.2%. And then of the 7 studies that did report specific reasons for patients who failed conservative management, there was a 9.4% rate of failure due to neurologic deficit, 52.8% due to back pain, 35.8% due to kyphotic deformity, and then about 2% for pain and kyphosis. Doing a pooling of only the randomized controlled trials and prospective cohort studies, there was a 3.6% rate failure of conservative management. Looking at predictors of conservative management failure, the demographic predictors, they looked at age, 2 of the studies found older age to be significantly predictive of failure, whereas 2 other studies found it to be not predictive. And there was an additional study by Azaria et al. that did show that younger age was associated with conservative management failure. It was noted that gender, BMI, smoking status were not significantly predictive of any failure. Looking at the clinical predictors of failure, a higher VAS pain score at admission was significantly predictive of failure, as well as a higher initial McCormick's load sharing classification score. And for radiographic predictors, in 2 of the studies, an increased kyphotic angulation admission measured by a Cobb angle was not significantly predictive. However, 2 other studies measured their kyphotic angulation as an angle between the adjacent intact end plates. One of them found that this kyphosis was significantly predictive of failure, while the other demonstrated a trend towards significance. Another additional radiographic predictor that they looked at was residual canal area, and they did find that smaller residual canal area at admission was predictive of failure of conservative management in 3 studies, whereas it was not significant in 1. The other radiographic predictor that they looked at was interpedicular distance, and both studies included in this systematic review and meta-analysis showed that increased interpedicular distance was significantly predictive of conservative management failure. Okay, so obviously management of thoracolumbar burst fractures is highly variable. An overall 9.2% of neuro-intact patients with thoracolumbar burst fractures did fail non-operative management in the studies included here, and the risk factors identified were potentially age, a higher VAS admission pain score, kyphotic deformity, interpedicular distance, residual canal area, and McCormick load sharing classification. There were some limitations to this study, including the heterogeneity of the studies included, as well as for the admission risk factors that are predictive of failure. They did include a T10 to L5 levels just due to the sparseness of literature on the topic. And that's it.
Great stuff, and thank you. So for a discussion, first of all, we have over 120 people around the world joining us live here. This is cool. Thank you, Jeff, for making this happen. We at SSF, we don't like boundaries. We want to have free quality content. So thank you all for making this happen and your interest. A special shout out again to Dr. Ahmad Fawad Pirzad from Afghanistan. He's been a long time loyal follower, and I hope, Ahmad, that you can come and see us one of these days live. But thank you for your comments and great questions. Also want to thank my partner, Amir Abdul Jabbar, who's covering for me right now. So question to you, this is a terrific talk, Dr. Eng. What do you do at USC? So you have an intact thoracolumbar fracture, a burst fracture. There's no ligament tear. It's an isolated injury. And you showed in your bibliography slide, the papers by Dr. Wood, that very clearly showed that non-operative care actually is pretty forgiving. So we know that. What are your thoughts? What do you do in real life at USC when you see a burst fracture coming in?
I think the first thing you want to do is get sort of upright radiographs or functional radiographs to determine whether or not it is a stable burst fracture. Obviously, if it's clearly unstable on these radiographs, you're going to trend towards operative management. But I think in a neurologically intact patient with a stable burst fracture, I think it's reasonable to opt for non-operative management initially.
First try. I'm going to ask a colleague, Dr. Elias from the University of Texas Southwestern Medical Center, to come up here. He's of great interest to me. He's a neurological surgeon, and he's an academic surgeon. He's been raised in Lebanon, and then he's done several fellowships in the U.S., one of us with us. So are we, from your big picture, big world perspective, over-operating intact burst fractures without, here, you take my seat, without ligament disruption? So Elias, take the seat.
Thank you, Dr. Chapman. First of all, I think this is a very important paper. I think we should take into consideration multiple factors. One of them is age and bone quality before we offer operation. I had one patient who was in her 70s. She had the T6 fracture, burst fracture, and I did upright X-rays with loading, end plate failed. I got also MRI, so I always get MRIs on all my patients. And I decided she needed the surgery. I did T2 to T, 2 level above, 2 level below. Unfortunately, because of the bad bone quality, she had LIV fracture. She came back a month later, 1 month later, with severe kyphosis, and she was not happy with her kyphosis. So I had to do a corpectomy with a cage and extension up and all the way down to L1. So although this paper showed 9% rate of neurologic deficit if we don't operate, I think I would take this shot and not jump directly on surgery in this age category and with patients who have like poor bone quality.
Great.
Now,
Yep.
now you asked me about if the US is overdoing it. I do not agree. I think it's proper. As a neurosurgeon, I would get standing X-ray, CT scan, and MRI. So always, whenever I have a resident on call, I would ask him, did you have MRI, CT, and standing X-ray to check the loading, and MRI to protect myself in case something goes wrong. So surgeons should take this into consideration also for medical legal purposes.
Thank you. Thank you, Liz. So, Dr. Eng, you identified osteoporosis as a variable that's significant. Nowadays, we can measure the Hounsfield units and get a pretty good surrogate for bone density. Is this something that you've seen in your clinical practice? Is this something that you've added to the assessment?
I don't think it's something that we routinely do in all patients, but if there's a concern for bone quality, I think it's a very reasonable thing to do to give you another sort of data point to consider.
We don't have a camera pan of the audience. We have a very nice audience here. Thank you all for coming. By a show of hands, who routinely nowadays uses the Hounsfield measurement tool when you have a CT scan? So show us a yes. That's probably 30%. Yeah, I think this is a very valuable tool. Jeff, is this something that you teach a lot now? Hounsfield units, is this part of your decision making?
I think it's very important, and I think it's important to take advantage of everything that you have and get as much information as you can. So I do think it's something that's very valuable, and I think it's something we should disseminate and make sure people understand it.
Very much so. Any other thoughts from your end? So how does this paper affect your management now?
I think certainly looking at the risk factors identified in the study and the individual patients that come in with these injuries can be important and sort of sway your decision one way or another. But I think opting for conservative management when able, I think it's still appropriate.
Great. Thank you. Great job. Yeah. Donnie, whilst we're getting ready for the next speaker, tell us about special collections and how we're going to rename those. What special collections with
We're not
GSJ mean?
renaming special collections, we're renaming special issues. But firstly, GSJ has special collections on our website, which are articles featured by topic, and they're updated every month when the new articles come out. So we have a wide range of topics from ACDF to lumbar spine, to thoracic, to trauma, to geriatric. And so if you are looking for articles on a particular topic, you can go to our website and you can find the special collections page and find every article we've ever published on that particular topic. And then we have special focus issues, which we're going to rename to focus issues so as not to confuse between the special collections. And those are issues that are published on a specific topic. One of the articles actually discussed today was from a focus issue from the Knowledge Forum of Trauma. So those are on a grouping of articles by a whole group together with a guest editor on a specific topic, whereas special collections are all the articles grouped by topic on the website.
Well, thank you. Dr. Wang.
Okay, we saved the best for last. I'm going to introduce our next fellow, Josh Pichet. Done an amazing job. Our fellows are almost at the end, so it's been a pleasure working with both of them. Josh is actually staying in academics, so we're very proud of him. So Josh Pichet, please come up and talk about the next article.
All right. Thank you, Dr. Wong. No disclosures. So the article I'll be presenting is called Implant Removal versus Implant Retention Following Posterior Surgical Stabilization of Thoracolumbar Burst Fractures. This was a systematic review and meta-analysis. It was done in 2022, and it came out of Australia. So as a bit of an introduction, the authors point out that implant removal following fixation for thoracolumbar burst fractures is controversial. Some of the pros of this can include reducing stress shielding, potentially decreasing adjacent segment disease, as well as avoiding instrument failure down the road. On the other hand, taking out their instrumentation, the worry is that you could possibly lose some of your correction, and develop gradual kyphosis over time. So with that in mind, the principal aim of this study was to evaluate the biomechanical as well as the functional outcomes of implant removal versus retention following treatment of thoracolumbar burst fractures. So for their methods, the authors performed a systematic review. The databases that they used included Medline, Embase, Google Scholar, as well as Cochrane. They did follow the PRISM guidelines for systematic reviews and meta-analyses, and their inclusion criteria was patients who had thoracolumbar burst fractures with or without neurologic deficits, and these patients all underwent posterior fixation with planned removal of the hardware at a later time. And importantly, and we'll get into this more later, there were patients included who both underwent and did not undergo arthrodesis in this study. So for risk of bias for the studies, the authors used the risk of bias randomized controlled trials 2 or the ROB2, as well as the risk of bias in non-randomized studies of interventions or the ROBINs to assess for this. And so this is the author's figure 1. So they ultimately found 751 studies in their initial search, and they narrowed this down to 13 studies, which they ultimately included. 12 of these were cohorts, and one of these was a case control study. And then of those 13 studies, 6 of them were ultimately able to be used for the meta-analysis portion. So some of the baseline characteristics, again, they included 13 studies, and this was composed of 673 total patients. The average age was about 40 years, but there was a range of about 13 to 70 in the studies. Over half the patients were male. The most common fracture level was L1. 11 of these studies used an open technique to fix the fractures. 2 of them used a percutaneous technique. And then importantly, only 1 study that was included actually performed fusion. And the most common implant removal time after fixation was 12 months, and there was a range of 10 to 24 months of within all the included studies. And so this is their figure 2. So this is the risk of bias assessment that they performed. I'll just turn your attention to the column on the far right. That's the overall risk of bias in all the studies. And as you can see, there's low risk of bias in all the studies except for 1, which is moderate. So diving into the results, so looking at Cobb angle, there were 7 studies that assessed for this, and these studies all showed that there was a significant loss of correction after implant removal. One example of this was in Chen et al. They showed that the average kyphosis pre-op was 23.7 degrees in their cohort. This improved to 3 degrees of lordosis post-op, but then they lost some correction, and patients had about a 4.2 degree average kyphosis at final follow-up after implant removal. However, the important thing to point out here is that of these 7 studies, only 2 studies actually dichotomized and looked at implant removal versus implant retention groups. And the 2 studies that did look at that, they found no significant difference in loss of correction between those 2 groups, between implant removal or retention. And looking at segmental motion between levels, so there are 2 studies that looked at this, and both studies showed that there was a significant improvement in overall segmental motion after implant removal. And those were the 2 studies that assessed for that. And this is important because ultimately, if you're preserving motion, the hope is that you're avoiding the risk of adjacent segment disease down the road. In regards to neurological status, 7 studies showed that there was no adverse outcomes in ASIA scores after taking out the implants. Looking at complications, Chow et al. Reported that screw breakage occurred in 8 out of 22 patients in their cohort. And Zhu et al. Reported that 5 out of 8 patients ended up needing a return to the OR to remove hardware for hardware-related complications. And diving into the actual meta-analysis data, so looking at Cobb angle, there were 6 studies that ultimately had data for this that they incorporated into the meta-analysis. And what they found was that operative intervention did improve overall pre-op kyphosis significantly by almost 17 degrees in the overall cohort. There was an average loss of correction, however, of almost 6 degrees at the time of implant removal and final follow-up. But again, the 2 studies that actually compared implant removal versus retention showed no difference in correction loss between the 2 groups. So those who underwent implant removal had about a 10-degree reduction loss at final follow-up, and that was the same in the implant retention group. The meta-analysis of VAS scores, 2 studies were included in this assessment, and they did show a statistically significant improvement in back pain in the implant removal group. And similarly, when looking at ODI, there was a statistically significant improvement in disability at final follow-up in the implant removal group. So I think overall, the strengths of this paper is that it was a systematic review and meta-analysis. So it's always nice to combine multiple studies. They analyzed both radiographic and functional outcomes, which I think is important. Obviously, patient-reported outcomes are just as important, if not more, than the ultimate radiographic image that you get at the end. And they did use moderate to high-quality studies with low risk of bias, which is also important when you're performing a meta-analysis. In regards to the limitations, only 2 studies directly compared implant removal versus retention. So I think down the road, this is something probably that we need to dive more into a little bit to get the power to better assess this. 12 out of the 13 studies did not perform a fusion. So I think the role of taking out the hardware in this group is a little bit less clear. And then no randomized trials were in this study. So that can obviously introduce some bias. So in conclusion, I think what they showed is that removing instrumentation after a posterior fixation of a burst fracture can improve quality of life without causing a worsening of kyphosis compared to implant retention. And that's in patients who are not undergoing fusion. And I think that's it. Thank you.
Great job, Josh. Thank you. So we have about 10 minutes for a discussion. So the first thing I want to ask you is the last sentence of your conclusion, and that is the fusion question. So first of all, why would one take hardware out in a thoracolumbar spine? I can think of 3 scenarios. One is a planned kind of a percutaneous fixation and removal after the fracture is healed. And I'll ask one of our UCSF colleagues to come up here to talk about that. The second is a so-called rod-long fused short construct. You're probably too young to know that, but there was a time where we did long constructs and just fused the fracture segment. The third is prominent hardware in a very thin patient. But the question to you now have is, did the authors ever look at actual fracture healing? Where, as old school people, and Bartolome will back me up on that, we considered a burst fracture well healed, surgical or non-surgical. If the traumatized upper end plate had actually healed, fused into the next plate, did they actually talk about fusion either basically spontaneous from the trauma or iatrogenic was actually successful or not?
So in this particular study, so the meta-analysis study that actually looked at, they didn't talk about that specifically. So these were all studies that looked at, they had planned hardware removal from the beginning. So they were not assessing ultimate fracture healing.
And then the second question I have analogous to that is high-risk patients.
Mm-hmm.
So a frequent thing, and this is what I'll ask one of our 2 colleagues, whoever you choose who comes up from UCSF. What I hear frequently being bantered around in our system is surgeons say, oh, I have a high-risk patient, and this is an unstable fracture. I'm just going to put some perk screws into them. And this is something that creates, I must confess, an kind of an anaphylactic response to me, because I think that's probably not a very good practice of medicine, but maybe I'm wrong. So I'm going to ask one of our younger colleagues to discuss this. Did the authors, in your analysis of the literature, actually differentiate high from low-risk patients?
No, they did not.
So for me, that's a significant bias. And again, the same thing goes into osteoporosis as a variable. So there's room for improvement, right?
Definitely. I would say so, especially looking at the fusion versus no fusion too, because only one study they actually fused. So I think there's definitely room for improvement.
So this was a great article again and great discussion. Stay on the stage. So who of you from UCSF will come up? One of you two. Okay. Ashraf will come back. So I'm an old geezer and I disclosed my anaphylaxis response to percutaneous screws in sick patients. Have a seat and tell us what your practice is. And I gave you 3 caveats. So fire away.
Yeah. So I think anytime we're doing surgery, we're weighing the risks against the benefits. And so in some patients, an open procedure may impart some risks. So the patient population specifically that we like to limit our soft tissue dissection are patients with marginal housing, patients with substance abuse problems, people who are not going to necessarily abide by sort of restrictions. And this question we frequently encounter in like orthopedic trauma as well. So if someone comes in with a tibia fracture, what is conservative treatment? Is it putting someone in a cast for 6 months that needs to be managed over a long period of time who may not be able to, or is it doing a surgery immediately where they can get up and start mobilizing? And that's a question I don't have the answer to. But I do think that considering percutaneous fixation in high-risk patients where you're concerned about wound compromise because of their either cachectic or poor social support, I think it's very reasonable as long as it's appropriate for the fracture at hand. So if something's a purely ligamentous injury, you're not going to rely on bone healing, then it might sway you to doing an open fusion.
Ashraf, let me push you and then I'll ask the other discussants to come up. So an old adage of posterior only treatment of thoracolumbar unstable injuries was more levels is better because you get an indirect reduction effort that's more predictable and you can get a better healing result. Short segment fixation always had a greater loss of reduction with it. It does not have the mechanics, there's subsidence or a toggle loosening of the hardware. So in this percutaneous era of young, facile surgeons like yourself, how do you integrate those two premises of longer fixation, better alignment?
I think the first question is the location of the fracture. So if someone comes in with an L3 fracture and you're considering 2 above, 2 below, that's an L1 to L5, which is a little bit different than if it's a T12 burst fracture where 2 above, 2 below only takes you down to L2. So that's one consideration. And the other issue where we do consider fusing long and or fusing short and instrumenting long, especially if there are contiguous injuries. So you don't want to stop at a level where there's an adjacent compression fracture.
So Neil Patel again from Seattle Science Foundation. I would like to know how many in the audience, how many people do percutaneous fusions first?
Percutaneous fusions or instrumentations?
Instrumentations, yeah. Okay, wow. And do you feel those who do percutaneous instrumentation, because this study showed 11 open and only 2 studies that did percutaneous for hardware removal. Open surgery, does that lead to worsening kyphosis or worsening loss of issues because now you have dissected the muscle away from the bone in terms of removal of hardware versus perc?
Okay. So David Gendelberg, UCSF. So I do think the soft tissue envelope is very important for stability, but I also think that some fractures do need a fusion, especially if there's like facet involvement during first fracture. And so one of the things that me and Dr. Olnaga do institute is we will percutaneously instrument long, but then we'll either put a tube down or make a mini open Wiltzie on either side and burr down the facets and the pars and do a selective fusion while instrumenting long and keeping the distal and proximal segments unfused. And then if the patient does well, we could then take out the hardware distally and proximally and restore some of that motion. And that's kind of our compromise between the biomechanics and maintaining the soft tissue viability.
How long do you wait till the hardware comes out?
Generally, I'll get a CT to make sure that there was fracture healing. I'd say the absolute earliest I'd personally be comfortable with is 9 months, but I prefer a year or longer.
And how long do you follow after that?
I'll follow them for 3 to 6 months, but if they're doing well, they'll present if they start having pain or something.
Anecdotally, have you had somebody you had to take back for worsening angles?
Actually, no, but also in all honesty, a lot of the patients don't come back to remove the hardware.
Yeah. And I think the question in terms of kyphosis also depends on how you're measuring the Cobb angle. Are you measuring it just at the level, like at the fractured vertebra, or are you spanning disc spaces that are now mobile? And that might account for the change of 7 degrees that you saw between the pre-hardware removal and the post-hardware removal. So how we're measuring the, our Cobb angle makes a difference.
Once you remove the hardware, what are the restrictions you place on patients in terms of mobility, yoga?
Just the standard soft tissue until the skin heals, but no restrictions thereafter. We get them involved with physical therapy to strengthen the paraspinal musculature.
And what about obesity in terms of percutaneous versus open?
I think it's, obesity, it makes cases a little bit more difficult with both, but I think you definitely have less soft tissue problems when you do it percutaneously. But I think everything should be driven not just by the patient's habitus, but more importantly, the stability of the fracture. And I think how you instrument is, I think it's very technique dependent. There's a lot of training bias. As long as you're able to maintain your stability, maintain your operative goals, I do think, we're going to continue to debate this because it's,
And in terms of technique, trying to find, re-engage the hardware in terms of perc, do you have any pearls about trying to get there and fish out the screws and caps?
Yeah. So even if percutaneous or MIS could mean people use that term differently. So some people make a long midline incision and go perk through the fascia, or you could go perk through just stab incisions for each of the individual towers. I think during my hardware removals, regardless of which approach was taken at the index surgery, we're doing small wiltsies, and especially in the sort of more lordotic lumbar spine, the incisions don't have to be too long. So either wiltsy impressions through the fascia through a single midline incision, I think helps us access and engage the screws for the hardware removal without stripping them.
Awesome. Thank you. So I have a question, Bartolome, kind of pump on you. I'm an older guy, okay? So we were taught 30 degrees of kyphosis and 20 degrees of kyphosis, and we got to operate. We're told, neurologically intact patient, 30 or 50% of canal compromise, you got to operate. We were taught all sorts of numbers. Are we now past numbers? Are we just going for our best gestalt and how the patient looks when we set them upright in a brace? Tell us about the fate of numbers and clear criteria for surgery outside of PLC disruption, dislocations, and neurologic trauma.
Well, in terms of A3 fracture or A3 or A4, there's the magical number, which is the kyphosis and also the compromise of the canal, which is different. And I have heard that the treatment of L3 fracture is completely different than the L1 or T12 because the biomechanic is completely different. The forces comes in a different way. I'm the oldest guy. I'm prone for the open surgery, small open surgery, even a single level. And what I haven't heard here is what happened with the disc. Remember, in the very old times, the one who designed the internal fixator, Walter Dick, talk about that because at that time, I'm talking about 30 years ago, that they don't fix it, they don't fuse it. But the problem that they has that fixation was because of the disc. Even though the vertebral body or the bone is healing. So take care about that. And I want to say a couple of things about conservative treatment. 1 minute. Yeah. Conservative treatment, what it is conservative treatment. The one that you give some medication and then you go and rehab the patient, or you put it in a cast for 12 weeks. Well, if you want to put this patient in a cast for 12 weeks, no way. This patient must be operated.
Thank you, Bartolome. So Josh, 30 seconds. How does this affect your treatment? If you have a patient at the University of Michigan where you're going to work and comes in with an old fracture and they complain of pain, are you going to take the hardware out or not?
Yeah, so I think in my practice, I would say if I've decided to fix it and I have not fused, then at 1 year, I think I'm going to plan to take out the hardware just to avoid the issues that we talked about. But in patients where I do a fusion for these fractures, I don't think I'm going to plan to take the hardware out unless there's an issue with either infection, painful hardware, something like that. And in that case, I'd probably want to get a CT before, make sure the fracture's healed, and then take it out if so.
Great. Thank you, Josh. Thank you for our 4 presenters. We'll put the final slide up. So this has been a unique collaboration, a first-time collaboration. I thank you all for coming. The Global Spine Journal is obviously near and dear to my heart, and I want to thank my partners, Dr. Wong over there, and Danielle Lieberman and Carsten for their great collaboration, our colleagues and friends at the SSF in Seattle, and all of you for being here. These are contentious times, these are hard times, and I love that handshake symbol because this is a chance for us to overcome all of our differences in a mutual partnership around the world. I want to really thank Globus also. There's a financial investment having this a live global broadcast without boundaries. So Globus was so kind to financially support this. So thank you for Globus. Our emails are listed here. I didn't put a QR code on. So if you have suggestions for a Global Spine Journal Club in the future, we can possibly run it up to 4 times a year. Let us know, and we'll be happy to facilitate that. It has to have a Global Spine Journal article as a subject. We'll be happy to facilitate. Any final words, Jeff?
I want to thank everyone for coming and the interest, and please consider the Global Spine Journal for your submissions, and if appropriate, consider it for citations.
Carsten?
Yeah, you made a good point. I also have to thank everyone. I think this was a great kickoff and a good start of more to come.
With that, we'll come to a conclusion. Thank you all for being here. Thank you for our guest discussants also, and our 4 fellows